Hello and welcome to TiCME, Time Critical Medical Education. My name's Dr. Nick Taylor and I'm an emergency physician based at the Canberra Hospital. Today's TiCME tutorial is all about shock. Now remember, if at any time you want to spend longer, at any point you can just press pause on the movie. So just before we kick off, we're going to go through the goals of today's tutorial. They are to understand the physiological tipping points that lead to shock, to learn how to classify shock, to learn how to be able to recognize shock clinically, and to attain the principles to select the right treatment for shock. Right, so to understand shock, we first have to try and understand the basic physiology of the circulation. Now, in my head, I see the circulation as being a little bit like a tree. So it starts with the trunk, and that's something like the aorta or one of the vena cava, and then it branches and branches and branches all the way down to the very tiny little twigs right at the end. Now each part of the circulation branches like this, and it can be a bit overwhelming to try and think of the circulation with all its branches. I think there was a reason why they taught us in undergraduate medicine invertebrate zoology and embryology, although at the time it seemed a little bit obscure. I think trying to pare all of that detail back, you end up with a circulation diagram that's not too dissimilar to that of a rudimentary invertebrate animal. Basically there's a big pipe with a few little valves or connectors in it, and this is what I've done with this diagram. So have a look at it and see if you can name all of the boxes. So how did you go? Essentially there's two halves to the circulation, an arterial side and a venous side. Now the halves are connected by these boxes with crosses in them. Anytime you see a box with a cross, that means that there's a capillary exchange bed. So the veins lead into the right hand side of the heart with deoxygenated blood. These two boxes in the heart are separated by valves. Blood flows into the pulmonary arteries where oxygen is brought into the circulation and carbon dioxide is excreted, and then pulmonary veins take the blood back through the left atrium where again valves connect to the left ventricle and out into the aorta. Blood flows round to the major arteries and then the smaller arteries and then the arterioles. Then we reach the end organs where capillary exchange beds exchange nutrients and waste products. Blood then flows back into the venules, back into the veins, and back into the SVC and the IVC into the right heart. The portal system is essentially an exchange system for nutrients in the gut. Okay, so we've got a rudimentary understanding of the anatomy and some of the physiology of the circulation. I just want you to think about how you would define shock now, remembering that shock doesn't have to be because the blood pressure is low. It doesn't have to be because there's not enough blood. It doesn't have to be because the patient doesn't have enough oxygen, although shock might be because all of those exist at the same time. Shock at the end of the day is a state where the delivery of substrates to the tissues is insufficient to meet their metabolic demands. So we're going to go back to the circulation diagram now, and this is why it's important to keep things simple. What we want to do now is look at our circulation diagram and try and work out the physiological tipping points that might lead to a shock state. So I want you to have a look at this diagram and just find 4 areas where if something goes wrong, then a sequence of events will lead to shock. So let's start. One of the most obvious places to start is the left ventricle, because if the left ventricle fails, blood can't go around the circulation. That makes sense. Then the main arteries. Well, if blood exits the main arteries, then clearly it can't be maintained within the circulation. The next point are in our capacitance vessels, so small arterioles and venules, and if they expand to a bigger size than normal, then blood will tend to pool in the peripheries and be taken away from the central circulation. And finally there's this magic idea of preload. So anything that clamps down on preload, so the filling of the left ventricle, could lead to shock state. So these tipping points actually neatly dovetail into our physiological classification of shock. Left ventricular dysfunction leads to cardiogenic shock. Blood exiting the circulation leads to hypovolemic shock. Third spacing of volume in the peripheries leads to distributive shock. And the failure of preload to return to the left ventricle leads to obstructive shock. Easy, isn't it? So let's talk about each of the causes of shock in turn. Let's start with cardiogenic shock, otherwise known as pump failure. Common causes include such obvious diagnoses as acute myocardial infarction, myocarditis, which is often a cause of cardiogenic shock in the younger person, cardiac arrhythmias, which are probably the most spectacular form of cardiogenic shock that we see, and sepsis in special situations because some of the circulating cytokines can cause direct myocardial depression. So remember that if there is a failure of contractility and stroke volume, then there will be shock, because stroke volume times heart rate equals cardiac output. Let's have a little look at an echo of a heart that is only just recovering after being cardioverted from a VT arrest. And you can see that the left ventricle here is very weakly contractile. This is the right ventricle and this is the right atrium, the left atrium. But if we look at the main pumping chamber of the heart, the left ventricle is hardly pumping at all. This person unfortunately was on a large dose of intravenous adrenaline as an infusion to try and keep their heart going. Unfortunately they didn't make it. Here's another cause of cardiogenic shock. It's a lovely 12-lead ECG showing all the features of ventricular tachycardia. This patient actually had a acute left main coronary artery occlusion as diagnosed by ST elevation in AVR on his 12-lead ECG. So after being cardioverted from his VT, we discovered the left main occlusion. He went straight to the cardiac catheter lab where he had his lesion ballooned and then stented, and he did very well. So what are the clinical signs of cardiogenic shock? Well, because there's decreased cardiac output and the body is trying to redistribute the circulation back to the core, the skin is cold and clammy and capillary return is reduced. Blood pressure is almost universally very low. Remember, blood pressure equals cardiac output times total peripheral resistance. And the pulse is often lower than expected for the blood pressure. And this can be for a couple of reasons, but usually it's because when the myocardial oxygen demand of the heart exceeds the supply, then bradycardia, or at least a lower heart rate, ensues, because when you have a tachycardic heart, the time for diastolic filling of the coronary arteries is reduced. Myocardial work increases when you have a tachycardic heart. So if you have a heart that's not functioning, it's really only able to go slowly so that filling of the coronary arteries can be maximised and work is reduced. Now remember, the JVP is usually elevated in cardiogenic shock because if blood isn't exiting the left ventricle, it has to go somewhere. And the lung fields for this reason are often wet, so you often see signs of acute pulmonary edema. What about distributive shock? So this is any situation where the capacitance small blood vessels become dilated. So the obvious ones that you know about are sepsis and burns. But then there's neurogenic shock, and this is special because in neurogenic shock there's a failure of the sympathetic nervous system. This causes unopposed dilatation of the peripheral vessels and also prevents tachycardia trying to compensate. So you end up with a patient who's both dilated and bradycardic, which is unusual. The other special form of distributive shock is anaphylaxis, and it's special because it's not only distributive shock that makes a patient very sick. In anaphylaxis there's also a direct myocardial depressant effect which causes cardiogenic shock, and of course you get the acute airway swelling in both the upper and lower airways, leading to severe bronchospasm and angioedema. The clinical signs of distributive shock make sense. So you've got dilated peripheries, so the patient's often warm. And this usually stays this way until very late. Remember, if they're septic, they'll often be febrile, and they're usually tachycardic, unless, of course, it's neurogenic shock. Usually the JVP is low because our blood volume is distributed in our third space, and the lung fields are not wet because there's no volume overload. Unless, of course, in severe sepsis or burns, you have established adult respiratory distress syndrome, which is a non-cardiogenic pulmonary edema. And occasionally, if anaphylaxis is the cause, you might have urticaria, wheeze, or angioedema, which might help make the diagnosis. Here's a parasternal long axis view echo of a patient with septic shock. Now this is a young male, and if you compare to our last echo, again, left ventricle, right ventricle, left atrium, mitral valve, and this is aortic valve here leading to the aorta, you can see how vigorous the posterior wall and the septum of the left ventricle are. In fact, the two walls are almost touching in systole, which tells us that the left ventricle is underfilled. You can also see how rapidly this heart is beating, trying to compensate for the low blood pressure which is being caused from the third spacing of fluid in the peripheries. So what about hypovolemic shock? Probably the most obvious subclassification of shock. Trauma being the obvious one, but also commonly in emergency departments, abdominal aortic aneurysm, GI bleeds, and ectopic pregnancies. If you ever find a shocked lady of childbearing age without an obvious cause, you should really assume ectopic until proven otherwise. So what are the clinical signs of hypovolemic shock? Well, the patient's often pale, and that's probably because they're anemic. They're usually cold and peripherally shut down, and remember, this is because the body's trying to redistribute blood back to the core by tightening up all the peripheral blood vessels. Usually the patient will be tachycardic as the patient tries to lift their cardiac output by increasing the heart rate, but beware the patient who's on rate-controlled drugs or an elite athlete who will have a lower heart rate than they should. The JVP is low, and the reason for that is because we are hypovolemic. The corollary is also the lung fields will not be wet in this circumstance because there's no volume overload. You need to do a clinical exam looking for causes of blood loss if there's no obvious ones found. So for example, melena or PV bleeding might give you a pointer. Here's a photo of my hand next to a patient who came in with a massive GI bleed. Their hemoglobin was 30. Here's an ultrasound image of a patient who presented with back pain and hypotension, and as you can see, this is a cross-section of the abdominal aorta showing an 8 cm abdominal aortic aneurysm with a bit of rim of free blood outside of the lumen. And the final subclass of shock is obstructive shock. What are the causes of it? Well, massive pulmonary embolus will completely clog the pulmonary arteries, leading to a failure of preload back into the left side of the heart. Cardiac tamponade, where the intrapericardial pressure exceeds the filling pressure in the right ventricle and right atrium, so blood cannot flow back into the right hand side of the heart. And tension pneumothorax, where the intrathoracic pressure becomes so great that not only is venous return completely impeded, but the superior vena cava can actually be kinked off as the mediastinum shifts. So what are the clinical signs of obstructive shock? Well, this is a bit of a mix of hypovolemia to some extent and cardiogenic. So you often get a peripherally shut down cold patient. They're usually tachycardic because the left heart's trying to work as hard as it can to overcome the lack of preload. But the JVP is often elevated because if that blood's not flowing back through the right hand side of the heart, it has to back up somewhere. The heart sounds are often muffled because you'll find that a layer of blood around the heart or air in the lungs in the pleural space will obscure the sound, so you have muffled heart sounds. You may have signs of midline shift, such as tracheal deviation in a pneumothorax, and you may actually find peripheral signs of DVT, which might help you diagnose pulmonary embolus. Here again is an echocardiogram, which I think is probably the best one I'll ever get of cardiac tamponade. This is a different view to the previous echoes we saw. This is a subcostal 4-chamber view, and you'll probably have difficulty working out the anatomy, so I'll help you out. This is the liver up here. This structure here is in fact the right ventricle. This structure is the left ventricle. This is the left atrium, this is the right atrium. This is the pericardium from parietal to visceral, and of course this means that all of this is pericardial fluid. Again, this is all pericardial fluid. Now remember that fluid is black in ultrasound, and there should be black in the left ventricle chamber and also in the right ventricle chamber, and you can see that there maybe is a thin sliver of fluid in the left ventricle, but very little else, and you can hardly see any fluid at all within the right ventricle. The other thing you notice is this strange movement of the right ventricular free wall and of the right atrium, and this is it collapsing as the pressure in the pericardial space exceeds the pressure in the right ventricle. So you can see why someone with acute cardiac tamponade has a very low blood pressure. There's basically no blood getting through at all. This patient had an emergency pericardial drain put in, and within 2 minutes the blood pressure was normal and the patient made urine for the first time in 24 hours. Here's a chest x-ray showing a huge left tension pneumothorax. Again, you can see just how much midline shift there is as all of this pressure has built up and pushed over the mediastinum. And here's an interesting chest x-ray sign. It may be one that you don't often see. It's certainly a bit of an older sign these days. But if you compare the right to the left, you'll see that there's lots of lung markings and vascular markings here on the left hemithorax. And on the right, you see prominence around the hilum, but really very little vascular markings anymore. So this is actually the Westermarck sign of acute pulmonary embolism. Essentially, a big blood clot has blocked the right main pulmonary artery, leading to no blood flow in the entire lung field. So this is Westermarck sign of massive PE. And if you do a modern test, the CTPA, you'll see large blood clot clogging the pulmonary arteries. So we've talked about the causes and the clinical signs of shock. So what are the effects of shock on the body? So let's go back to our schematic. Remember what shock was? An inadequate delivery of substrate to the tissues. So it's obvious that shock will cause end organ dysfunction, which leads us to the effects of shock. And remember, the effects of shock are just going to be the effects of end organ dysfunction. So the question is, how are we going to work out whether end organs aren't working properly? Well, let's see. So if we don't get enough oxygen into our tissues, we're going to have to try and generate energy through different means, and that means anaerobic metabolism. So how are we going to measure that? Well, that's with a blood lactate. Often a lot of blood gas analyzers that are found within emergency departments will also do a spot lactate at the same time. The kidneys are an end organ, and when they become dysfunctional, they're going to try desperately to hold on to as much circulation as they can. So we'll measure how dysfunctional they are by urine output. So an early IDC measuring hourly urine output is important. The brain's an end organ, and reduced cerebral perfusion will be measured by conscious state and cognitive awareness. The skin's an end organ, and reduced skin perfusion is easy to measure. The patient will be cold, clammy, and they'll have decreased capillary refill. The heart's an end organ, and reduced myocardial perfusion can be measured by seeing ischemic ECG changes such as lateral ST depression and T-wave inversion on the ECG. And the gut's an end organ, and reduced splanchnic circulation causes reduced bowel sounds and often an ileus. So how do we recognise shock? Well, there's a couple of things that can help. There's a principle called the shock index, which is essentially the heart rate divided by the systolic blood pressure. And this has been studied quite a bit since it was first sort of come up with in the late 90s, and essentially will predict for a worse outcome in critically ill people. So basically, if a shock index is greater than 0.9, you'll do worse. So you don't have to be very sick for that. That essentially means, for example, a heart rate of 90 and a systolic blood pressure of 100. You might not have thought that person was too sick using those two numbers, but the shock index would tell you that they have a chance of doing worse than someone whose shock index is less. A normal shock index is less than about 0.6. Certainly a very unwell person with a heart rate of 120 and a systolic blood pressure of 60 has a shock index of 2. Remember that we should be able to use a venous blood gas plus or minus a lactate and a base excess very early on to try and work out whether there's signs of anaerobic metabolism. We should put in an IDC nice and early to be able to assess urinal output and response to treatment. It's very important. Don't forget that a patient who's on heart rate control drugs or those who have a impaired sympathetic nervous system will have a heart rate which will not respond as it should. And remember the young person who will compensate terrifically well right up to the point where they fall in a hole. And we often see the young septic patient actually arrive hypertensive. But the key is they're febrile and very, very tachycardic, and they've got a very good sympathetic nervous system. So they're actually tightening up as best they can, they're increasing their cardiac output, then all of a sudden all that compensation fails and they fall in a massive hole. Remember also the elite athlete whose resting heart rate might be 40, so 80 for them is very tachycardic. So we've talked about recognition of shock, and now we move on to treatment of shock. Well, treatment of shock, once we've subclassified it, is really easy. It's treat the cause. So, for hypovolemic shock, the treatment is treat the cause. Stop the bleeding. And this is why a trauma patient who arrives with hypotension at positive fast goes straight to the operating theatre. You need to replace the lost fluid, and remember that a large diameter short bore cannula is best for fluid resuscitation. If blood loss is the feature, then you should be giving O negative blood and then wait for your cross match. Crystalloid or colloid, it doesn't really matter. In our department we certainly use crystalloid for everything. Cardiogenic shock, the treatment, surprisingly, is treat the cause. So someone who's blocked off their LAD needs thrombolysis or an angiogram. Sometimes they need emergency cabbages. Someone who's having an arrhythmia needs to have their arrhythmia cardioverted, or they're not going to get better. You also need to help the heart out. Sometimes you need inotropes such as dobutamine to give some positive beta effect. You need to help offload the heart as well, because reducing afterload will certainly help cardiac output, and sometimes reducing preloaded and overloaded heart will help as well. And in extreme circumstances, a balloon pump to augment diastolic filling of the coronary arteries is also beneficial. For distributive shock, it's not surprising that the treatment is treat the cause. There's a very marked correlation between time to antibiotic administration and survival in severe sepsis. So as soon as you recognise sepsis, you need to get the antibiotics in. Stop any vasodilators that the patient might be on. Fill up the dilated saggy bag full of fluid, and if that's not successful, you need to tighten the saggy bag up. And remember that alpha agonists are vasopressors because alpha receptors are in the peripheral vessels. Noradrenaline would be the archetype used as an infusion. Adrenaline will work for nearly everything, and it's particularly good in anaphylaxis because it's got the beta agonism as well for the lungs and for the heart, which will help the other features of anaphylaxis. For obstructive shock, I'm sure you're getting the hang of this now. The treatment is treat the cause. So you need to drain the tamponade, you need to decompress the pneumothorax, and you need to thrombolyse the pulmonary embolism. Just a quick note on decompressing pneumothoraces. Did you know that about 50% of the adult population is now too large to have their pneumothorax decompressed with a standard 16-gauge cannula? So it's important that you open the chest cavity as soon as possible in a patient with a tension. Helping the heart out in obstructive shock is also sometimes required. So remember, the problem is with preload, and so sometimes a judicious amount of intravenous fluid, and we usually use something like 250 ml boluses to see what effect it will have, will often just help augment that preload and filling of the left ventricle. Often the patient's so sick they also need pressors and or inotropes to just help them through the tough period. So, we've gone through the physiological principles of shock, the clinical signs of shock, how to recognise shock, and also the basic treatment principles. Let's now work our way through a few basic cases to practice. So, 38-year-old male's in your emergency department. You think he's got E. coli bacteremia because his urine lights up like a Christmas tree. His temperature's 39.5. He's very tachycardic. You've given him 6 litres of normal saline and he's still hypotensive. What do you add now? So first of all, what sort of shock is this? Well, it's clearly septic, and septic falls under distributive shock. So remember the distributive shock, we have dilated peripheral blood vessels. So the treatment is, once we've filled them, and we've clearly filled them with 6 litres of fluid, we need to tighten those blood vessels up. This patient needs alpha agonism, and whether you give them a small dose initially of metaraminol while waiting for extra help, or you start them on a noradrenaline infusion, depends on your level of experience. What about a 40-year-old with a high fever? Now when you examine them, they seem to be a bit peripherally shut down. Mum says they haven't had a wet nappy in 10 hours, and they're very tachycardic. You've already given them 10 ml per kilogram of normal saline. What do you do now? So the first question is this patient shocked? Well, we haven't got a blood pressure, but we do have signs of end organ dysfunction in that there is reduced urine output and the patient's tachycardic and the skin is shut down and clammy. So I think we could say the patient is shocked, but have they had adequate volume replacement for their distributive shock yet? Well, 10 ml per kilogram, if you equated that to an adult, that's about the same as giving half to 1 bag of saline. Do you think that that would be adequate? And in a child, it's not adequate either. So we need to repeat the fluid boluses, and in fact you might repeat 10 to 20 ml per kilogram another 2 or 3 times. Usually in children, this is enough to reverse the signs of shock and make the child 100% better. It's very occasional that a child would need to be placed on vasopressor support for their infection. What about this one? A 19-year-old man drives his car into a tree, comes into your emergency department with a blood pressure of 75 on 45, tachycardic, with a bag of saline running. What now? Well, in a really severe situation like this, it helps to try and immediately subclassify the cause of this man's shock. Now, he's had a car accident, so the thing we need to immediately think about is hypovolemia. If you have the capacity to do a fast scan, then that will tell you whether or not there's free intraperitoneal blood. We also use ultrasound to look at the lung fields and the heart to determine whether there is a tension pneumothorax or cardiac tamponade as a cause of the shock. So clearly, if we can immediately work out that this man has intra-abdominal injury, then everything from here needs to be going to theatre as soon as possible. And if you're in a small place, that means activating retrieval as soon as possible or calling in your general surgeon if available. In the meantime, if blood loss is the cause, then O-negative blood should be administered as soon as possible. We also need, as we said, to consider the alternative diagnoses of tension pneumothorax or massive hemothorax and cardiac tamponade. If you don't have ultrasound facility, then an urgent chest x-ray and a good clinical exam should help you try and work out what's going on. Finally, a 60-year-old male comes in with chest pain and hypotension. The first thing to consider is what are the differential diagnoses in this age group and this gender which could lead to this shocked state. Remember to think in terms of physiological consequences, so is this man likely to have distributive shock, for example? Well, we don't have a story of fever, and he's got chest pain, so distributive shock seems less likely, although if he definitely had pneumonia, you might reconsider. What about obstructive shock? Well, massive pulmonary embolism could be an acute cause of hypotension and chest pain, so we'll keep that in mind. What about cardiogenic shock? Well, I think playing likelihoods, a 60-year-old male with chest pain is probably more likely to have cardiogenic shock than any of the other causes, so we should consider acute myocardial infarction. And hypovolemic shock, although associated with chest pain in this instance, a rupture of an abdominal aortic aneurysm or dissection of a thoracic aortic aneurysm could cause these features. So at the moment, we've got 3 types of shock that could be causing this man's presentation. Probably the best start is a very quick directed history and an emergent 12-lead ECG. 12-lead ECG will tell you whether this man is having myocardial infarction. Will also give you pointers for pulmonary embolism. If it's completely normal and the man still has symptoms, then a rapid abdominal examination and an emergent chest X-ray would be the next test. From here, it depends on what's available within your department to work through his problem. In our department, I would use an ultrasound machine to help me evaluate not only his abdominal aorta, but his thoracic aorta and his heart, as well as lung fields, to rapidly help us determine the problem. That concludes today's tutorial about shock. I hope it's been helpful for you to get a basic understanding of the subclassifications of shock and how you might approach a very unwell, undifferentiated patient in your emergency department. Thank you very much for watching this TiCME tutorial, and I hope to see you next time.